This is RadPod, a podcast produced by ASMERT, the Australian Society of Medical Imaging and Radiation Therapy. ASMERT acknowledges the Bunurong people as the traditional owners of the land from which we record this podcast and pays respect to elders past and present. Hello, I'm Steve Lacey and I'm the Director of Education for ASMERT. Picture this. You're working a late shift in the emergency department and you have a relatively fit 18-year-old patient who has come into your x-ray room for a standard x-ray of her wrist following a fall off an e-bike. Your patient is sitting in the chair chatting away with you and you've taken your PA wrist and you're about to do the lateral when the patient suddenly goes really quiet and collapses. Now, the same could be said for an otherwise well patient undergoing radiation therapy. So what would you do? Would you feel comfortable being able to respond to this in an effective way? These are such common scenarios and it's incredibly important for us to recognise and respond to patient deterioration at all levels. And I'm joined today by Scott Cooper. So Scott is a paramedic with the Queensland Ambulance Service and also a non-practising radiographer. His work has taken him into the clinical education space and he spends a lot of his time now delivering education in managing anaphylactic reactions. So Scott, welcome to RadPod.
Thanks so much, Steve. It's great to be here and thanks for the invite.
No problem at all. So I've given the examples of how patient deterioration could happen to anyone, anywhere. And we were also given a real life example in a previous episode when Bruce Harvey was talking about an elderly patient who came in for back pain and ended up dying in the x-ray room from a dissecting aorta. But these types of situations have been occurring for decades. So Scott, what has sparked this recent focus on training medical radiation practitioners in recognising patient deterioration?
Good question. I guess it's multifaceted because you can look at the latest changes to APRA's core capabilities for MRPs, which includes that MRPs are trained in recognising patient deterioration. But you can also look at the evolution of MRPs in general and how they've almost been sidelined away from that primary clinical care role. So as we move towards the changes in March, it's important that all MRPs are aware of their responsibilities and give them the tools and knowledge that they need to be able to recognise deterioration in a patient.
Yeah. Okay. So I'm not saying that I've ever thought this myself, but I know others who have been ingrained in what they think is their scope of practice and that responding to a deteriorating patient might be outside of that scope. So it's kind of like, oh, I guess I just have to push the red button and people are just going to come flying. And this is more of a doctor or a nurse problem. How would you respond to people who think like that?
Yeah, that's a really great question. And I think we do still have certain people within the MRP community who do think like that. Part of bringing technologists along the journey to become more clinicians, rather than just being technically proficient, but also being clinically proficient as well. And that enables them to play a greater role in monitoring deterioration. And I guess the other part of this is that, yes, you can say that I work in a hospital, I have a MET team, or I work in a clinic and I can just call 000. And whilst that is true, we have to be understanding and cognizant that it may take some minutes for the MET team to actually reach you. And if you call an ambulance, they may not be there straight away. We all know about the pressures on hospitals and pressures on ambulance services these days. So you may be responsible for managing that patient. This is about getting to the point where you can actually recognize deterioration prior to making a MET call. Obviously, if you still need to, you can. But what we're looking for is those early changes that the MRPs can detect and then hopefully intervene prior to us needing to hit the MET button or calling 000.
Yeah, at the Royal Children's Hospital in Melbourne, they refer to their basic life support training as the first 3 minutes, because that's generally how long it will take for the appropriate help to arrive once you actually call for the MET call itself. So how do you see this training complementing rather than replacing the roles of other healthcare professionals?
This is meant to augment the existing safeguards and protocols we have. Obviously, in a lot of places, we still work closely with RNs and radiologists and other healthcare professionals. It's certainly not meant to ever replace those roles. They'll always have a role to play. What this is about actually integrating MRPs into that fold, where they spend time with a patient, may be the first ones to actually detect that something is wrong, something subtle like a bit of shortness of breath or their heart rate may be up. So it's about complementing those roles as opposed to replacing them.
So Scott, you come from a radiography background, but now you're non-practicing. How did you get involved in developing this training for medical radiation professionals? Was it a personal or a professional experience that motivated you with this?
Definitely both. I started with the anaphylaxis following the Peter Hickey case, which my wife brought that home and told me about that. And I actually heard them presented at the Cairns ASMERT conference. And that sort of triggered this, me thinking back to my time as a radiographer and what I knew then versus what I know now. And all of a sudden I was like, oh my God, I actually had no idea. I thought I did, but I didn't. So I guess I could now apply the knowledge I had as a paramedic back to what I knew then. And that started me down this path of writing an anaphylaxis package, and that's led into the patient deterioration package, which is about patient safety. And it's about ensuring that our patients are safe when they come to our practices and to our medical imaging departments. and empowering MRPs as well to be broadened into part of the wider healthcare circle rather than being off to the side and, I hate this term, but button pushers and that's all you do. It's about that growth in profession.
Yeah, absolutely. How much additional training do you think is required for medical radiation professionals to become confident in recognising and responding to the deterioration?
That's something that a lot of people are concerned about, and they feel that, oh my God, I'm going to have to go learn what nurses learn or learn what doctors learn. And that's certainly not true. Deterioration, in essence, has very few core appearances. And regardless of what the actual etiology is, the deterioration signs tend to be very similar, be it from a lacerated liver or a stroke or some other cause. If we can just train MRPs in some really basic observations, what I call analog observations in the training, and also a few digital observations, which would just be blood pressure, temperature, and SpO2, combine those two things with just a slight change in their approach to patient care, which is one of curiosity, rather than referring to the patient of, oh, that's my chest or that's my foot, being a bit more curious about their condition and what brought them in. When you combine those two things, it's actually a really powerful tool to detect that deterioration early. You certainly don't need any sort of high-level education or complex diagnostic equipment.
But we're also not talking about having to know the expected respiration rate or anything like that, or what's the expected heart rate that we should be seeing.
No.
That's the kind of high-level stuff that you're referring to, yeah?
Correct. Yeah, that's absolutely correct. I mean, if you put someone in a room, a bunch of MRPs in a room with, a patient having an asthma attack, you'd see it very easily. They'd know there's something wrong there. You can very easily see that person struggling to breathe. And just the same, whether they're looking flushed or just taking a simple pulse rate, you tell if someone had a tachycardic fast pulse or whether it was slow. So these are really simple observations that anybody can do, even the first aider could do them. That once you're cognizant of them and you just know something isn't right, again, the goal is not to say, oh, I think this person's having a heart attack or I think this person's got a dissected aneurysm. It's about going, something's not right. I'm going to escalate this up.
Yeah, absolutely. When you deliver the training yourself, what is involved? How do you deliver it?
Yeah, so it's still currently going through, the final stages, but it will be online and it will be a self-paced course. And it's going to be covering topics such as why are we here? How do I detect deterioration? What actually is deterioration? How do I escalate care once I've detected it? And then crisis resource management. So it's kind of a holistic package to empower MRPs and to actually make them feel more confident in going, hey, something's not right here and I want to get someone to check this patient out, rather than just going, I'll just knock off this ankle x-ray, get them out of my department, then they can be someone else's problem.
And how do you know that what you're delivering is relevant, realistic and achievable for the scope of the professionals?
Yeah, it's a good question. And, this isn't Scott Cooper's version of the world and as well as a paramedic. This is everything that's basically taught comes from the Australian Health Standards, which is recommended by APRA. And the second part of that question would be the relevance and achievability. And I really want to make sure that this was something that could be introduced into practice in busy environment. Whilst I'm out of the game now, I still understand, the absolute pressures and workloads on people. So it's not like you have to do a blood pressure on everyone or, take a full medical history. It's not about that. It's just about integrating these subtle changes with the patients that you detect something's not quite right. If your patient's happy, laughing, fit, healthy, chatting to you, there's nothing to do. But maybe if the patient's coughing or wincing or just looking uncomfortable, that would be the time that you'd actually interject and say, hey, what's going on for you? Do you mind if I take your pulse or do you mind if I get a blood pressure? So we're talking about a very small cohort of patients.
So that brings me to my next question, and I'm going to play devil's advocate a little bit here, Scott. We're now in this day and age where everyone's busy. There's so many patients coming through. People are talking about staff shortages and all that kind of stuff. How can they realistically integrate this training into their day-to-day practice without compromising the patient flow or imaging efficiency? So what strategies do you provide to help them apply this knowledge in a time pressure setting? I don't necessarily just mean responding to the patient. I also mean giving them time to actually get the training to be able to respond as well.
I guess the access to training is the biggest issue. I know in paramedicine, we really struggle to actually get off road to do our practicals and our assessments. So this is going to be delivered online. So it'll be accessible 24/7. So you can do it in between night shifts or in between patients if you're lucky enough to be in a practice that you have time between patients. But it is going to be very accessible. And then the application of it, we're not talking about assessing every single patient comprehensively. It's just that one patient you go, they look like they're in a lot of pain. Or there's something not quite right there. They're the ones that maybe you spend, and I'm talking literally, 1 to 2 minutes extra, just getting that information and then maybe bumping it up to the ward or calling the ED and say, hey, this patient's got this, this, and this. Would you mind just coming over and checking them out?
Well, not only that, it could also save yourself an extra 20 minutes of the patient actually passing out in your x-ray room as well.
That's exactly right. I mean, no one wants patients deteriorating in their department, that's for sure. So it's about patient safety at the end of the day. And I was very cognizant when I was writing this package that it couldn't be so complex that private practices were going to go, well, there's no way we can do this because we're just too busy, and same for the public hospitals. But it kind of fits into both public and private, whether you call 000, whether you have like a radiologist on site or you don't, whether you've got nursing staff on site. We have to get away from that. There'll always be someone there because there will not always be someone there. You know? Yeah. Like you said, the 3 minutes, ambulances are supposed to be there within like 8 minutes for a code 1. Sometimes it doesn't happen because of the workload. So we've got to be cognizant of that we may be the ones. But again, it's not about that response. It's about that detection earlier on. So it's not replacing first aid or ALS. It's about that detection first so that they don't get to that point in the first place.
Yeah. Now, I can imagine that some medical radiation professionals might feel a bit anxious about taking on extra responsibility or potentially missing the signs of deterioration and what that might actually mean for them professionally. How do you address these types of concerns in the training?
I think most healthcare professionals don't like change. And we want things to change. So we are a bit of a dichotomy, I think, all healthcare professionals like that. Although this sounds like a big change, it really isn't. The training is, like I said, very, very simple. And I guess the second part of that question would be that fear around, what if I miss deterioration? Well, any training is better than no training. And if you look at around hospitals, consultants miss deterioration. Experienced nurses miss deterioration. We're not saying that you're always going to be able to spot it. We're just saying it's going to improve your chances of spotting it. Yeah. And very simple tools. It's not something that you're going to all of a sudden be legally responsible for because you didn't spot the patient having the MI or the ruptured spleen. It's just about putting these small things in place to increase safety. We'll never get to 100% safe, but we're trying to improve it.
Yeah. And what kind of feedback have you received from practitioners who have already completed the course?
Very positive, actually. I struggled a bit in the first place because I had to remember I'm coming from a paramedic perspective and I had to make sure that it was relevant to MRPs. Obviously, anatomy is not really an issue, but pathophysiology and like trauma and deterioration are very new concepts that we had to get across. So anyone who's done the course so far has found it really, really useful, really easy to apply. And then the ones that have done it have also gone back then onto their departments and then liaised with the nursing staff, with the doctors and just said, hey, do you mind just running me through like the observation? Do you mind if I just quickly do a blood pressure and do an SpO2 and a couple of things like that? They've actually been really keen to get upskilled in that area. Majority of people have been really excited to do it because if you look at like the circles of all the healthcare sectors, we're trying to create that Venn diagram of patient safety where everyone overlaps, that safety blankets over all our patients. And it's just not reasonable to accept that a patient can come to a medical imaging department for an hour and a half and not be at least observed or at least for the MRP to not detect when that patient's deteriorating.
Yeah. And part of your training also introduces the concept of crisis resource management. For those who are unfamiliar with it, can you explain what it is?
Yeah, sure. So crisis resource management is a sequence of soft skills. So not technical skills, they're soft skills. And it's all about communication, teamwork, leadership, and how to work as a team when responding to a crisis. It began in the aviation sector. I think it was in the early 80s initially, where they found that several high-profile aircraft crashes caused not by technical failure, not by a lack of proficiency amongst the crews, but by a breakdown in communication. And that power imbalance was one of the key things they found, that, the captain's word was God, and you never questioned that. So they're now in looking forward to about the last 40 years. It's now in pretty much every high-risk industry. It's in mining, it's in anesthetics, it's in the military, it's definitely in paramedicine. And I think there's definite value in bringing it into the world of medical imaging as well. So it's primarily focused around communications and teamwork skills so that even though you may not be directly responsible for responding to a patient in crisis, you can then be part of that team.
Yeah, wonderful. Scott, thanks so much for coming in and giving us all of this information all the way from Cairns in Queensland. ASMERT do try to put on as many of Scott's courses all over the country as they possibly can, but now obviously we're shifting to that online. Where will people be able to access this online?
Yeah, so ASMERT will be hosting the package. It is going to be available through ASMERT online quite shortly. Just the finishing touches are being put to the program, and also we're going to chunk this one up into blocks of learning so that it just makes it easier to digest each part as you go. So look for that coming through very shortly. And if you do have any questions, just reach out to ASMERT and I'm sure they can direct you to the right place if you can't find it.
Wonderful. Thanks again for joining us, Scott.
No, thanks for having me. I really appreciate it. Thanks, Steve.
Thanks for listening to RadPod, a podcast produced by the Australian Society of Medical Imaging and Radiation Therapy.